Doing a few cases with Dr. Ramlaw way back in 2017, and he definitely puts an interesting thought process out there. Imagine 5 to 10 years from now, you have to ramp up and check your notes to do an AVR because you haven't done one in a long time, and you've got to make sure that you have the equipment there. It hasn't expired on the shelf. It's really an interesting thought exercise in many ways. I will be brief here today. I am going to rehash some of the info that I spoke about last year at this same conference on the same topic. Spend about 20 minutes going over that again, and then bring up some new thought processes, some new information going forward on how we can understand the perfusion services sector of healthcare. Last year I just called this talk Supply and Demand in the Perfusion Services Sector, and this is the 2019 update. It's really been a pleasure to be back here at Sanibel. I love Sanibel Island and all the seashells they have there. So I think all of us know that there's strong anecdotal evidence that supply and demand is much tighter than in the past. Anecdotally, I think about 3 to 4 years ago, I really saw things start to tighten up, and it seems to have gotten even tighter every day or every year as it goes by. One of the things I look at is personal reports. What locations or people do I know of who have jobs that are open for 12 months or longer? And another kind of anecdotal proxy is how long before graduation are students employed, or how long have they, before graduation, have they secured employment? You know, I was at Texas Heart for a long time, and it used to be you'd have some students graduate without a job and then get a job in the first month. Then it kind of crept up. About 8 weeks beforehand, the last person would get a job. Last year when I gave this talk, I had talked to some of the students who were still there, and it was getting closer to 16 weeks. The last person to get a job had a job 16 weeks before graduation. And now I haven't talked to anyone this year, but I'm suspicious that it's maybe not the last person, but it's getting closer that the majority of the students have jobs secured 6 months before graduation. Maybe not everybody, but the majority. And again, those are anecdotal observations. I posted this also last year from Linda. Linda put this out in 2016 on the specialty care website, and I think at the time, you know, there was some discussion that there was going to be a school in Philadelphia, and there was some consternation. I think there was conflicting beliefs about that. Now I think it looks, in hindsight, it looks very prescient. She definitely was right. There was a shortage of clinicians, but we just don't know what it is. And so what I'm going to cover today is documented demand data, and that gets a little fuzzy as I'll elucidate. Supply data, which is much more easy to determine, but we'll also look at some other market data as I did last year. And then that's where I'm going to kind of expand, as Susan alluded to. I don't have all the data from my doctoral research here to present today. I defend next week, so hopefully I'll be back next year to present all those reams of data that I've collected. But I will go into some theories that I came to understand as part of my research. And I'm going to call those new tools for evaluation. And then, of course, the fantastic thing here is that we often have great feedback and insight from the audience. So, all the demand data I'm going to show you is from the Healthcare Cost and Utilization Project. This is a subdivision of the U.S. Department of Health and Human Services. You can look up procedures by clinical classification software, DRG, ICD-9 codes. It is usually a very good tool for assessing healthcare. The only thing is that the data, it's the most comprehensive resource available, but the data lags, and that's one of the problems that we have. Perfusion is a tight market, or it can be. With such a small number of clinicians, you can have really what's referred to as a constrained resource, or a rate-limiting step in your chemical reaction. A small change in the number of clinicians can drastically affect the balance that you have. So here's the demand data, and this is clinical classification software code 44, coronary artery bypass graft. This is data only through 2014. And what you see is many surgical experts consider 1997-ish to be the height of surgical CV, cardiovascular surgical volume. And you have 402,000 procedures, And then in 2014, the most recent year I have data for, you're down to a little over 200,000. That's a significant decline. Here we have procedure code 43, heart valve procedures. Now my understanding is that this does include TAVR, but I'm going to put an asterisk on that because I stand to be corrected in case that's not the case. Again, 1997. So although we saw a decline in CABG volume from 1997 to 2014, we saw an increase to just under 150,000, and this represents a 70% increase from 1997. However, the total number of procedures compared to CABGs is much lower. So although this is a 70% increase, it's 70% of a smaller number. Let's see, did I skip one? No. Here's aortic resections. I suspect that this was a coding error in this year, but as Dr. Ramlawi alluded to, we've had a very stable surgical volume there, no major changes. Again, I think that was a coding issue. I did include code 49, other heart procedures, because I think that there's a lot of cases that we're now on standby for that are complicated, they're maybes, there's something that the risk profile of the litigious nature of healthcare indicates maybe we're standing by for more procedures. Maybe not PCIs, but more surgical procedures. And so I kind of included those here just to take a look at them. There has been an increase since 1997, but not a dramatic one. And again, the total number of procedures is lower than CABG. So let's look at ECMO. And I'm really sorry to tell everyone, nobody did any ECMO in 2015. But unfortunately, this great repository of data has a small problem in that in the shift to there's a little notation here, and if you go to HCUP's website, this notation will tell you that the data is not available because of a change to ICD-10 coding classifications. Now, I'm not an expert in how to use this system, and I've asked for additional help in kind of trying to mine the data. But with this being a free service, it's not that easy. So I'm going to continue to work with it, and if anybody knows how to get around this loophole, I'm interested to hear it. But certainly the ECMO trend, I strongly suspect, it's significantly higher here. Every day you hear about facilities opening ECMO programs. And let's see if I have any asterisks here. You know, this represents a substantial increase. Again, the total volume of procedures is low compared to CABG, but the thing that we really don't know, despite all the workforce studies that we have in perfusion, is what are the manpower hours spent by perfusionists on ECMO? A lot of the surveys in the past have looked at whether or not perfusionists are involved in ECMO, but they don't have an absolute value. There's no quantification of the time spent or the FTEs expended on ECMO care. And there's really no standardized method of care. Some facilities have perfusion in-house, some facilities have perfusion at bedside, different ratios, 1-to-1, 2-to-1. Some facilities have RRTs or RNs manage it. It really crosses the entire spectrum. So for some reason, when you try to summarize all this data and get it into 2015, because of those coding changes, even those cases that had codes through 2014, they were all affected. So here's the 2015 data here for everything except ECMO. And unfortunately, what I'm saying is that 2014 is the best data we have, and that's 5 years old. But in general, we do know some procedures are up, some are down, and this goes back to what Dr. Ramlawi was saying. The recent data, what we have is really not sufficient to make any decisions. Not including ECMO, as of 2014, the total number of procedures since 1997 is down 16%. So our demand, not counting ECMO, is down 16% from the heyday of 1997. But we also know not all workforce demands are equivalent. Maybe ECMO is sucking up a huge number of hours of perfusionists across the country. And also importantly, this data does not include the number of sites. When you think about AMSEC's recommendation for the N+1 guideline, that's going to disproportionately affect smaller facilities, because adding a second perfusionist to a 1 or 2 OR facility is going to increase the manpower demand 30% approximately. Adding 1 perfusionist to a 10 OR large academic medical center is obviously only going to increase the demand 10%. And so that's what the need is for us, or at least the best estimation of what we know. Let's talk about the supply of perfusionists, because the market forces are where the supply meets the demand. And this is pretty well established. This slide was presented by Kirti Patel in 2016 at the CREF meeting. The program at the Memorial Hermann UT Health facility in Houston was the first program to open in 20-ish years, and it took the number of accredited programs from 16 to 17. Now, I think within the last 6 to 12 months, the program in Philadelphia, I think it's called the Thomas Jefferson program, went from provision to be fully accredited. That's my understanding. It's now listed. So we're now at 18 programs, but certainly a significant decline since the heyday of 1997. And again, this is kind of in lockstep with the surgical volume. So it's similar to what we would anticipate. So we know the number of schools is lower, but the number of graduates surprisingly has been more constant. It's been preserved despite the decrease in the number of schools. And this is the 18-year trend in certified clinical perfusionists. And you see here the total number of certifications has increased every year, year over year, since 2000. And there's never been a single year of decreases in the number of cardiovascular perfusionists. The lost certifications had a small tick up in 2016 and 2017, but it's now back in line with previous numbers. So despite the perception, there certainly has not as of yet been a massive exodus of any number of clinicians, at least from the aspect or from the perspective of who holds the license, who could work if they wanted to. And that number has been preserved. Again, just highlighting that. When you do the math, the total number of perfusionists from 2000 to 2018 has increased 28%. That's pretty substantial, but it's also interesting to note that's a substantial increase in the supply of clinicians at a time when, not counting ECMO, the demand, surgical demand in volume has gone down 16%. Those numbers don't seem to paint the picture of what we're seeing today. So I'm just restating here what I had. Through 2014, there's been a decline in traditional perfusion demand, not counting ECMO. And in the same period of time, there's been a pretty substantial increase in the number of licensed perfusionists. So we need to look for additional metrics to better understand the workforce needs in the United States, because if we were to take these traditional data points and look at them, the picture that we see is completely different from the reality that is on the ground. And if we use these to predict future needs, we're going to run into problems. I presented these last year. Maybe what's happening is perfusionists are becoming less efficient. People are spending time cleaning heater coolers, but that's a pretty big number to have to explain, a 40% swing, which is what the math tells you. Maybe the system is becoming less efficient. I know that you have an increasing number of cases done at lower volume facilities. Maybe the cases are longer, so perfusionists, instead of doing 2 5-hour cases, are doing 1 9-hour case. Maybe there's more cases that perfusionists are doing which are not easily captured by the H-cup data. Maybe people are doing a lot of chemotherapeutic treatments or ex vivo lung, or that N+1 is really having an impact on the demand for clinicians. Maybe since 2014 there's been a rapid increase in case volume, but again, it would have to be about a 40% increase to account for the swing that we're seeing. Maybe there's been an increase in perfusionists exiting the field, but maintaining licensure or possibly working part-time. And that way we don't see that exodus in the ABCP numbers. Probably what's likely, but I cannot conclude is that some combination of the above variables are in play, especially since the gap is so big. We would probably need to see input from a couple of different variables to soak up that 40% swing. So I think the first survey or the first notation that I noted, which had a real public prediction of perfusion shortage, was the 2010 Wisconsin Perfusion Society. Ms. Sutton was generous enough to send this to me. This was presented at the meeting, submitted for publication, but never published because there were concerns about the sampling procedure for this population studied. And it was a convenience sample. There wasn't a random selection of participants, but it was, I think it was an electronic survey. Nevertheless, this survey had a substantial portion of perfusionists exiting the field in 2014, 2015. Remember, this survey was conducted in late 2007, 2008. So a large swath of perfusionists retiring here, and another large swath of perfusionists retiring here, which is right where we're at. Now together, this is 12% and another 15, let's call it, ballpark estimate. What's interesting to note is this was a prediction, and this was, these are demographic trends. Eventually, these people are going to retire. Whether or not they've retired yet, when you go back and look at the ABCP data, it says no. Because although we have slightly increased the number of graduates, if these people had retired, the total number, in these predicted numbers, the total number of perfusionists, clinical perfusionists, certainly would have shrunk in a given year. 12% in a 18 to 24 month window represents, 350, 400 people ballpark, and there's never been a year since 1997 that we've graduated that many students. So we've never seen a shrink in the number of CCPs. Brian was kind enough again last year to provide me with this data. Again, this is just anecdotal observations, and this is through the perfusion.com portal. You've got the jobs posted. Interestingly, the number of jobs posted has increased despite that surgical decline that we've observed through 2014. And what's interesting is that although the surgical cases are coming down during this period of time, and we have good data through 2014, the number of jobs open or posted has increased during this same period of time. Now, the number of applicants has certainly come down and rebounded here, but this certainly looks like a scarce marketplace where people are looking for clinicians, they're looking for talent. So as I said, through 2018, there hasn't been a substantial increase in the number of licenses lost or retired, and there's never been a year of decline in the absolute number of perfusionists. Despite the predicted survey, the survey which predicted mass exodus in 2014, 2015, and another one coming up here starting this month or last month or within the next few months. It's interesting to note this isn't a very strong study. It's for physicians. I think it's out of Canada. But physicians, this data for physicians shows that the actual retirement date tends to lag 2 to 3 years behind the predicted date. So maybe that's what we're seeing here. It's just a theory. It's not an explanation. But let's slow down and look at some new tools for evaluation. And this is where I had pulled up some additional research as part of my graduate school, and I found this is a commentary. It's not it is peer reviewed, but it's a commentary, and it's published in the Journal of Allied Health. And I know I like to think of perfusionists as mid-level providers. We don't deal with the population as a whole, but the area that we encompass clinically is right in that same ballpark. And Allied Health sometimes encompasses mid-level providers, sometimes it doesn't. But I think that this is a great resource, this article. And it's referenced here at the end, so you can go and look at it. But it's a good way to evaluate healthcare labor markets so that educational programs can plan for their future. And I found this article to be very interesting because it's all about relative supply and demand. And they take this equation basically, and what they do is they use U.S. Census Bureau data, And the US Census Bureau does an excellent job of tracking the number of people and the salaries of those people, but they don't track perfusion because it's too small. And that's one of the big obstacles that we see, is we don't have any good absolute data on salaries. And although the ABCP serves as a good proxy, we don't really have an actual number of people who are practicing perfusion in the US. So this commentary this is a percent change, but they do it year by year, and you can do it year by year. They take the salary of the clinician and the number of clinicians and compare it to the salary of a physician and the number of physicians, and they do it in a year-over-year basis to see increases in demand by noting the salary change relative to the clinician number change relative to the number of physicians and their salaries. So it sounds kind of complicated, but when you look at the data, and I'll show you in a slide or two, it really produces a very elegant method for looking at the market forces in play relative to physicians. It's not a perfect absolute value, but when you understand that, I mean, nothing gets done in healthcare essentially without physicians, right? It can show you where things are going, because without the physicians, you can't do those procedures anyway. No one's coming to heart surgery solely by seeing a PA or solely by, they're going through a cardiologist, they're going through a primary care provider. So it's a really great way to analyze things. However, it may pose some problems for perfusionists. So this is a single graph, and I'll show you a more elegant one here. But this is just to get you familiarized with this graph here. So this is more clinicians compared to physicians. This is less clinicians compared to physicians. This is a wage increase that is greater than the wage increase physicians have seen. And this is a wage decrease compared to the physician's salary or income, I guess is a good way to put it. So you can do this in a single year, and then you can trend it year over year. And I thought I reversed this slide. So the next slide is going to have a more detailed explanation. But here's what you've got. You're always going to have your physicians in the middle, right? So let's look at this. I think this is a 5-year trend, and it's detailed occupational categories, and unfortunately there's no perfusionists here. So what can this tell you? And this tells you about what the market forces are doing net of all impacts. So here you have physician assistants. Over 5 years, there has been an increase in the number of physician assistants relative to MDs, and despite that increase, they've had a massive wage increase. And what does that tell you? The demand for their services is through the roof. They're increasing their number of clinicians. Despite that increase, the demand is so high that their salaries continue to rise. Okay? What do you have down here for counselors? Counselors have slowed down the number of graduates. People have left the workforce that haven't been replaced. Their schools are not graduating as many people. And despite slowing down because they maybe anticipate a decrease in demand, despite that, they continue to not keep pace with the wage of physicians. Obviously, we're not talking about 1-to-1. We're talking about a ratio, right? They tend to not keep pace in these salaries. Nursing aides, same thing. A pretty significant decrease, and LPNs, licensed practical nurses, a significant decrease in the number of clinicians. And despite that decrease, you've got their wage has remained relatively stable. But this is the sector you don't want to be in. If you want to make a lot of money and work hard, this is the sector you want to be in. Somewhere in the center is a great place to be because you're going to be keeping up, at least relative to physicians. And the goal here is again to assess, and here's the 4 quadrants. It's just an explanation. But it's all relative, and the quadrants are good for knowing where you are and kind of planning for where you want to go. And the 5-year trend can really show you what's been happening. So I put this up there with a big asterisk. Can we use this data? Because, or can we use this model to look at perfusionists? And the answer is it's very tricky, because we have salary data for perfusionists, but out of all these studies, only one, Monjero and Brewer, or Brewer and Monjero. That was peer-reviewed data, but it was only females. This is the only peer-reviewed study in here that covered a large number of people. This was an anecdotal survey. My data has not yet been peer-reviewed, and the data I'm going to post up here is just a guess based on looking at the numbers. And Huckabee had great surveys, captured a lot of responses, and in some ways took it on the chin with a lot of criticism for what I thought was great work. But anyways, here's the salary trend, as you see, for Perfusion. It's not surprising, it's not shocking, but the problem is this data has not been, it's not well elucidated enough that we could really use it in this fashion. And I've gone back and tried to make this assessment using this, this model. To tell you the truth, I'm still working on it, but the model that they use, it's kind of difficult to get the data out of the U.S. Census Bureau. It is a public access. Anyone can go in and get it, but it takes quite a bit of skill to understand how to do it, and I'm still working on it. So another thing that Susan alluded to that a lot of you have probably seen is the survey that I put out as part of my graduate school program. And that's to look at vacancy and turnover. And I really like this number because, number one, it's used in a lot of other healthcare fields. Number two, it's not as sensitive perhaps as salary data. When you talk about salary, I think that people tend to get touchy. I think that there's certainly an understanding there. I will tell you that I'm going to go back and look at it, but just anecdotally, on the survey that I conducted, the response rate for the salary question was probably the lowest. If it wasn't the lowest, it was the second lowest response question that was answered in the survey. And specifically, when looking at that question with my committee, we put that was optional because it was suspected that if that question was required to be answered, the number of completed surveys would go down significantly. So it's pretty easy to define vacancy and turnover. Vacancy is the number of currently open positions you have over the total number of budgeted positions. Turnover, did I say turnover? That's vacancy. Turnover is the number of positions that you filled during the prior 12 months divided by the total number of budgeted positions. And this is a really simple but elegant tool because it's net of all influences. If your surgical volume is going down, you're not likely to post that vacancy, and so it closes the loop, so to speak. And it's easier to get than salary data. So with that being said, the survey's already closed. Don't attempt to go there. But during the last couple days of January and February of this year, as part of my graduate school research project, I conducted a vacancy and turnover survey of perfusionists in the United States. I posted it through PerfList, PerfMail, on AMSECT. Frank April was very nice to post it on Circuit Surfers. I posted it through some social media sites. It was highly distributed, I guess is the best way to put it. And I got a good response rate, but as Susan said, I am defending next week, so I don't have that data to present just yet, but I'm hoping that I can either come back next year or submit for publication or both and talk to everyone about what these numbers will say to us. I do want to, the results are coming soon. I hope you all are eagerly awaiting the publication of those numbers. And as I put up the references here, I will say that last year this talk generated quite a bit of discussion, and Bill Huckabee was here. I don't know if he's here this year, but I really am interested to hear, kind of as a follow-up, it won't be included in any publication, but what does everyone see out there, and what are they feeling on where the boots hit the ground on what it's like looking for people to hire? And I think this transitions well into our after break discussion. What are people looking for in new hires? What are you looking for in resumes, and how are you approaching those challenges? So with that, I will open it up for questions.